Good afternoon, everyone, and welcome to today's Hofstra webinar. Very pleased to be among the Hofstra community today. My name is Stu Almer. I am a senior-level healthcare executive in the field for many years, and the last 10 years in long-term care. Today's program is titled The Future of Long-Term Care. I know that a number of students are on today's webinar. I hope that many of my students are on as well, and I hope that all of you find it very enjoyable. I know that I enjoy my work in the field for many, many years. As I said, today's subject is the future of long-term care. There's good news here. There's really good news at the start. The good news is that we're going to be around. We have our challenges. We are going through dramatic change, and not just dramatic, it's unprecedented. And it's not so much the amount of change that we're going through in the long-term care side. We're going through it through all of healthcare. But it's the type of change as well as the volume of change all at the same time. But we need to take care of our seniors. Our senior population is growing at an incredible rate. There are, in 2013, over 40 million individuals aged 65 and older. And if you looked at projections ahead over the next 30 years, that number is going to more than double. We'll have over 80 million seniors over the age of 65. It's incredible. So we'll be around. We will be in the people business. The service industry will survive, but it's changing, and it's changing much faster than anyone ever would have anticipated. So this large census population growth is really the impact of the baby boomer generation. We're starting to see the oldest of the baby boomers needing healthcare services, and those needs are going to grow. Because as we know from our experience over the last 20 or so years, as folks age, they develop more issues and they have more needs. So in order to support this growth in the aging population and needs that exist, the healthcare system, many would argue, has weakened. What we've seen over the past many years, and it's interesting, we've never really seen it in this part of the country. We've seen closures, and not just of long-term care facilities. We've seen closures of hospitals. We have seen mergers, facilities coming together more for a matter of survival than anything else. We're seeing acquisitions at an incredible rate. We see parties that maybe at one time were not working together or looking to work together, or maybe had very different philosophies and approaches, now all of a sudden saying, hey, we need to look at this differently and work together. And I can tell you from my own many experiences, there are other facilities, vendors, who maybe we didn't work with, and now we need to take a closer look at. We're also seeing at the same time what's causing all of these closures, mergers, acquisitions. We're seeing the impact of a bad economy. We're coming out of a bad economy. Many would argue we're still in it. But I think the theme that you'll hear me talk about today is that as we grow and as things change, we all have to figure out a way how to support the future of long-term care. So just talking about the current landscape for a moment, we're seeing tremendous regulation. This is a very heavily regulated field, whether you're on the hospital side, the nursing home side. It really doesn't matter, but we're seeing regulation far and above anything before. It's interesting. I don't think a week goes by that I don't hear about some new regulatory requirement that now we must comply with. In addition, and again because we're coming out of a tough economy, we're seeing audits. We're all experiencing audits from insurers and other agencies, all with the goal of trying to strengthen the economy, and they're looking at us. We're a target, and often it's called fraud. It's an attempt really to scrutinize what we're doing, and it's forcing us to be more efficient than ever before. And also competition. There has always been competition, there will always be competition, but that's also greater than ever. So when you put all of these three pieces together, it's almost a perfect storm scenario. It's so much happening all at the same time. and you could look at this and say, is it bleak? What's the forecast? I'm one of those who believes very strongly we will be fine. I think if you embrace the changes and you think creatively and work with partners and work very hard at a grassroots level, this can be overcome. One of the things we're seeing most of right now is a change in the insurance industry. We're hearing about managed long-term care plans. My organization, the Parker Jewish Institute for Healthcare and Rehabilitation in New Hyde Park, has been embracing the changes, and we are a lead partner in an insurance product, as many others are doing, all designed to secure our base, secure the programs that we have, and then we hope to grow things from there. So again, if you take a proactive approach like this, you can survive what is a difficult climate. So looking ahead, I think I mentioned this before, the population growth that we expect over the next 30 or 40 years is going to be staggering, and therefore the need will be there. But in order to support all this change, we have to sacrifice. So on the federal impact side, we have what's known as the Affordable Care Act, also known commonly as Obamacare. I believe very strongly that from a conceptual standpoint and dealing with the greater good of society and taking care of Americans and providing good health care, that the Affordable Care Act is the right thing to do. So if I'm a consumer and I'm reading about Obamacare, I would be very pleased to see that our uninsured population are going to be insured, that it will maybe be a system that encompasses care for everyone. I'm all for that. However, being on the provider side, operating a facility, my concern is, can we afford to continue operating and support this growth? Because to have the growth, the change is costly, and everyone has to pay a price, pay a piece of it in order to survive and then to thrive. We're seeing certainly tremendous cuts to the Medicare program, and that's of great concern. Numbers that are talked about for future reductions are staggering. I know that my colleagues and I share the concern. We deal with this every year. We hear about draconian cuts, significant cuts, and we have to fight it. We have to fight it together, strong as an industry. But we do recognize the uninsured do need to be covered. Many years ago, there are many who began to advocate on behalf of a mandated program for Americans, or, quote, socialized medicine. I don't think we can stop that. I think that's coming no matter what we do. I think folks like Hillary Clinton began pioneering that some 20-plus years ago. Some may criticize President Obama for his efforts in bringing about Obamacare. I think whether he did this now or not, or to this degree, I don't think we can stop. I think the crest of the wave is here, and it's coming down, and it's really just a matter of how we address it. But who will fund it? Certainly on the state level, we have our share of issues in the state. We have an aging population. They all have complex needs. In 2011, it was initiated by Governor Cuomo. He was the new Governor Cuomo at the time, to develop what he called a Medicaid Redesign Team. And he pulled together top experts in the field and the local industry to come up with recommendations in order to address the economic issues in the state and also the health care issues that exist in the state. And really, there were 79 recommendations which came out of the team. And in looking at the 79 recommendations, they were largely geared looking at lowering costs, and again, to help us address what is a difficult economy, but also focus on quality. And if those of you who do a lot of reading on the subject and where we're going, you'll see quality is key to the success. There are many factors, but you're going to see the theme of quality. So one of the things that's come out of the MRT recommendations is what's called QAPI, Quality Assurance Performance Improvement. It's taking the quality efforts that those of us in healthcare, and especially in long-term care, have been doing for many years and taking it to another level. And we have to take things to another level, not just in quality and leadership in many areas, if we're going to be successful in this difficult climate. QAPI is going to focus on design, scope, governance. What's the board's role in addressing quality and ensuring that we have proper quality programs and that we truly improve? Data, looking at data is going to be absolutely critical. It has been for some time, but again, we'll go to the next level. And don't be fooled. The insurance companies, they have our data. They know a lot about us. I have had to deal with issues where an insurer will say, why is your length of stay this? Or, look at other issues or look at falls. They have that information. It's available. And you have to be able to identify these things on your own and address them. Okay, in terms of cost, the Medicaid Redesign Team, from a cost standpoint, has been very successful. $4 billion in year one have been saved. We're all now subject to what's called a global spending cap. And periodically we see reports that are we spending as healthcare in New York State below a cap? And there are caps for home care, there are caps for adult day care, for nursing home care. Altogether, overall, we meaning the providers, are well under our spending cap. So that's a good thing. The global spending cap, by the way, is tied to the consumer price index. Now, the concern we have is if we exceed the cap overall, and in any particular area, but mostly overall, then that's something we'd have to worry about, because that then gives tremendous power and influence to the Department of Health and to DOB, the Division of Budget, because then they will be charged with the mandate to implement action should that occur. But so far, since this has been in play since 2011, overall in New York we've been under the cap, and we hope that we can stay that way. But in order to stay that way, it's going to continue that great effort that we've been talking about. In terms of managed long-term care, I mentioned managed long-term care in terms of an insurance product in New York State. And one of the key aspects of managed long-term care is assuming risk, meaning that an insurance company will look at a population, a community, and go at risk, meaning take the dollars, take the premium for that individual times those in the community, and provide care within a budget. It's one way to look at it in terms of a budget, and manage the healthcare needs. Some might say that's rationing healthcare, but we've been in the managed care environment now for some time. But now what's happening is the nursing homes, long-term care is catching up. And by the way, I should preface this that when I talk about long-term care, really not just talking about nursing home care. We're talking about adult day care. We're talking about hospice care. We're talking about home care, which is a significant piece of all of long-term care. And everything is at risk. So now we're seeing through insurance mandatory enrollment. So folks who maybe previously came to a nursing home under a Medicaid stay or under a Medicare stay now all of a sudden need to select an insurance plan, an insurance product. And those who don't select a product ultimately will be automatically assigned to a plan. So we could see some time ago that this is the way the industry was going. When the managed long-term care plans came into play a couple of years ago, they were really designed initially to address adult day care and home health care. But we could see that this would eventually, if successful and saving the state dollars, bring in long-term care into the fold. So now we're seeing our permanent residents falling under this program. And some of you may have heard the acronym FIDA, which stands for Federally Integrated Dual Eligibles, dual members. So we're talking about individuals who are both Medicaid, and Medicare insured combined. So those individuals, close to 200,000 of them in New York State, will now be eligible and in a sense required to be in a managed long-term care plan. And it's ironic, you know, we've for many years have been focusing on a federal level in keeping people at home. It's the home care programs like Adult Day and home care that have been under the greatest scrutiny, because now they are big targets. And as they are big targets, and when I say big target, meaning a lot of dollars is spent in those areas are being ratcheted down as well. The future. I believe that we will further fall into this managed care environment. And as I just said a few moments ago, nursing homes, permanent residents in nursing homes will fall under this as well. Then you're hearing also, I'm sure, through the Affordable Care Act about health insurance exchanges. This is what one would call a marketplace that now is looking to place New Yorkers into designated new health insurance programs. And so folks who maybe were not insured before will now, in a sense, be forced into it. Employers will be forced to provide, to be in the health insurance exchange marketplace as well, and if not, there are penalties involved. I think, again, conceptually, these are good things that need to happen. It's how they roll out, and that it's happening so rapidly that one could argue it's damaging to the system. But this does provide opportunities for nursing homes. We have not previously been the driver. We've been an important part of the healthcare marketplace. The hospitals have certainly had the lead role. Hospitals will continue to be in the lead role, but I believe now we have a greater seat at the table. And I think it's only a good thing for long-term care. And again, one of the reasons why I'm staying positive about the future. More about the future. As you see on this slide, these are just some of the other new acronyms, new programs that are being rolled out that we'll all need to participate in. There are ACOs, which are provider organizations of providers, mostly physicians, coming together, and their reimbursement is tied to quality. Then there is what is called bundling. Bundling is the receipt of payment to care for an individual that the hospital will receive, and the nursing home will be one of a few parties to share in those dollars. And if we provide good care, good quality, we will share in some of those savings. So again, this provides nursing homes an opportunity to work more closely with hospitals. Readmissions. This has been a focus for the last several years and is even becoming greater. Many are looking at admissions to hospitals from nursing homes and then readmissions. It's very important that you know your data, that you know how long your patients are staying in your facility, how often they're going to the hospital. If they're readmitted, are they being readmitted within 30 days? 30 days is the trigger. Another model we're seeing are called health homes. This is a new care coordination model with a focus on information technology and outcomes. And we're seeing other quality payment incentives. But again, quality is the same thing through each of these objectives, and it's important that you know your data. Embracing the changes, well, we can embrace them, but we'll need strong leadership. We'll need good, young, solid leaders who are willing to take risks. Many of you, I know, are young students on the call. We need you to step up and have that passion that I bring to my work each and every day, embracing the changes and providing strong leadership. I believe one of the future webinars to be held, hopefully in the next several weeks, will be on leadership. I know Professor Skanga, many of you know, is expected to host a program titled Leadership. It should be a great program for all of you to participate in. Lobby. I don't mean stand in the lobby. I mean we need to lobby. We need to have our legislators in line with us. Our legislators need to know the issues. They have to be able to rely on us to provide them with the information so they can fight the fight with us in Albany and beyond. Have them to your facilities. Have them get to know you. If they don't know you and they don't know the issues and they can't support you, they can't lobby effectively. And again, keep an eye on quality. And last, as I've said many times already in this short webinar, the importance of embracing the changes. That concludes my brief and hopefully informative presentation, and I'd be happy to entertain any questions that the audience might have. Thank you. Okay, we have a question. The first question that's come in is, what is the hospital's role in this transition? Good question. As I said before, the hospital really is in the lead here. We are working more and more closely with our local hospitals, and for example, with our nearest facility, which is Long Island Jewish Medical Center within the North Shore Long Island Jewish Health System, we're working much more closely with the emergency department, with physicians, with physician leadership, and with the hospitalist teams, hospitalists who care for patients admitted by individuals' own private physicians. By working at a grassroots level and securing these relationships, we can do a better job, because I mentioned before, we need to reduce admissions to the hospital, reduce readmissions, and the only way to do that is to work closely with the hospitals. We're doing it, and we all need to be doing that. Also, take advantage of those bundling opportunities that I mentioned. That certainly is designed to have the hospitals and nursing homes work closer together. Okay, the next question, will the slides be made available? Yes, the slides from this program will be made available on the website, and they will be, I understand they'll be emailed as well, so you will have access to this. Are there any other questions? Okay, another question that's come in. How will long-term care facilities adapt in the event the Affordable Care Act is modified or weakened by the federal government? Another very good question. I think I mentioned earlier that the Affordable Care Act is coming at a great expense to all of us, and we worry daily, can we afford this? Are we going to be able to afford to provide health insurance for our employees? Are we going to be able to afford staffing our facilities at the level of which we staff them? So it's funny, if it's weakened or modified, that could be a good thing for long-term care, because it could be less of a financial impact on us. But we're going to see a lot of change, whether it costs more, costs less. Things are going to change a great deal. We have to kind of wait and see how this develops. No one would have thought 3 years ago we'd be going through what we're experiencing right now. Okay, there's another question came in. What role do you see ambulatory care playing in the changes? They will play a significant role. I believe I mentioned home care, adult day care is all outpatient ambulatory based. They're already being affected. I don't think these programs will go away. I don't see how they will go away. The population we serve is a very smart, very demanding population, and we want to be taken care of at home. We want to be able to have good access, good outpatient care. So they're certainly part of the equation. As a long-term care provider that has many ambulatory programs, we know the value and the importance that these programs have. Some 25, 30 years ago, the typical nursing home was a 20-bed facility that 200-bed facility that did not have any other programs. That's changed. Most long-term care providers are now providing short-term rehabilitation, adult day care. We're seeing social day care grow a great deal. So I think they will play part in the changes. I don't know if they will play as significant a role as the hospital is playing in all of this, and then the nursing home, but will be an important part. Okay, we have another question that's come in. With continued cuts in Medicare and Medicaid, how does strategic planning get prepared? Oh, I love this question. It's funny. For many years, the subject of strategic planning kind of went out the window because things, I'm talking about many years ago, change was happening so rapidly. How do you even plan for the future? It's becoming even more difficult now with what's happening. Strategic planning has to be done now daily. I mean, I recall early in my career, 25 or plus years ago, we would have strategic planning sessions once a month or once a quarter. I think to keep up with what's happening, it's a daily process. The management team, and not just senior leadership, the management staff have to come together and be involved in that change. We meet literally daily, and we talk about impacts to our programs. You need to know your data on a daily basis, have dashboards, be able to respond to changes as they're happening in your facilities. That's the only way to then adjust and plan effectively. Great question. You're all asking many great questions. I have another one here. Is New York State unique in terms of these changes? New York is not unique. Other states have gone through this process as well. We are maybe going through it a little bit more dramatically in this state, and I think we're affected a little bit more because we have a greater indigent population. This is a very heavily unionized state, and also New York State is the leader in medical education. We're training the most young people to be doctors in this state. And so therefore, I think you put it all together, we're impacted more than most, but we're not unique. However, if you look at published data across the country, if you look at states and what they're spending per patient per day, you'll see that New York still spends more per patient per day, or this region, the Northeast, is spending more per patient per day than compared to other parts of the country. That's a little bit scary because that tells you that those who are looking at this from an overall budget standpoint can carve out more out of the system, can carve out more out of healthcare. So we're really going through that process now. We're going through the pain, and we're catching up with the rest of the country. Again, somewhat unfortunately, but in some ways, it's forcing us to provide even better care and do some things better. When I talk about those 79 Medicaid Redesign Team initiatives, they're very good initiatives. Many of them are addressing issues and needs that we've had in long-term care for some time. So you can look at this from a positive standpoint, that it's addressing issues we have, not just an impact on the bottom line. Next question. How do you see the transition of reimbursement from volume to value-based? Well, if you heard my theme of quality, it's all on that. Reimbursement is now very much tied to quality. So, and also in the insurance industry, and looking at risk, we often have to look at our volume and say, you know what, we will do better financially by maybe working harder so we keep someone out of the facility. So we may see less volume, but we would expect and hope that we would be rewarded for that. And that's really the transition that we're going through right now. Good question. Okay, the next question. Now there are 100 days per year. Oh, okay, 100 days of coverage per year under Medicare. When will Medicare become fully Medicaid? How will the payments be handled? I believe that's premature. I think early in 2014, this question is going to come up. There are a lot of questions on the table right now. There are questions about, many of you may be familiar with a 3-day qualifying stay under Medicare before someone is eligible to come into a nursing home for rehabilitation. That issue may go away. That will be a wonderful thing for access into our rehab facilities. So a good question, but I think we have to see how that will be handled. Okay, lots of questions. Do you think the primary care providers are vested in the upcoming changes? That's great. I don't know if they are so fully vested in terms of nursing homes and docs working together, not where we need to be. I think they're understanding that they need to be part of some organization that that looks at quality, that looks at care being provided. That's why the ACO that I mentioned on one of the slides, Accountable Care Organization, is important, because we're all being driven to participate together and provide good quality. The hospitals, we're being forced to work together. It's a good thing. We want to work together. We believe that, in a way, being forced is not such a bad thing. Same thing with the physicians. So I think they're vested. I think it just takes a while for everyone to come along. Okay, been asked, is the patient-centered medical home model the same or similar as the home health model? Yes, it is, and it can take many different forms in terms of how it actually looks as a model. But patient-centered medical home is synonymous with the home health home model. Okay, waiting. I see we have another question coming in, so please wait a moment. While my assistant here, Tasha's doing a great job. She's writing down the questions. Okay, how do you see the new observation ruling of the 2 midnight rule for acute care affecting skilled nursing facilities? Okay, well, I mentioned before the 3-day requirement rule. That going away could be a good thing. A 2-night rule for acute care observation, let me just explain so everyone understands what we're talking about. If someone goes into a hospital and they are in an emergency room and they are there for an observation, that is now not reimbursable. That does not make that day or that stay eligible for nursing home care. So we as long-term care providers are opposed to that. We'd like to see that go away. We think it'll be easier for patients to get access to skilled nursing facilities if that were abolished. Okay, we have another question coming in. Do you see contracts between nursing homes and ACOs in light of continued focus on 30-day readmission rates? I'm not sure I'm following the question, but there will be much contracting between ACOs and nursing homes. We want to be able to participate with the ACOs, which are mostly physician-driven, because we want to be able to provide services to the patients that the ACO is going at risk for. The ACO is going to look at a population and go at risk. We want to be a player in that. And the penalties, if this answers the question, I think the penalties that will affect us on patients who are readmitted could very well affect the ACOs as well. We're all bound, we're all in this together, and we're all going to be affected by the same quality initiatives. Okay, question, and what will these contracts look like? I think it's premature to see what that looks like yet. The ACOs are still in the development stage, and so I don't think we really know yet what that's going to look like for long-term care providers. Okay, how will patient outcomes be impacted? Well, we hope positively. You know, managed care is not new in New York State in 2013. It may be newer to long-term care. We're hopefully committed to the same good outcomes. We don't want to see patients discharged too soon from the hospital and where they get turned back around again. Although there's great scrutiny on us, we are seeing everyone having to look at quality. So outcomes may improve. I think that also remains to be seen. I think we have another question coming in. I'm very impressed by these questions. Okay, Got at least one more. Discuss the relationship between age-well and Parker Jewish. Why will this promote greater access to more patient populations? Well, I don't know if that will promote greater access. I think what it will do, what I know it will do, is it will help secure the patient base that we have. So if we were not partnered in an insurance product, we as an institute would need to contract with other insurance companies, negotiate rates for the care that we provide. And we're doing that. We're doing that anyway. We're working with many, many insurers. But we believe that by being vested in an insurance company ourselves, we'd have a seat at the table, a greater opportunity, maybe be in a stronger position to negotiate those rates. So I don't think it will be an access issue. I think it will allow us to secure the patients that we have, because right now the marketplace is crazy. We are seeing patients, community members being enrolled into plans at an incredible rate. Marketing initiatives are off the charts. So we'd rather see them in a plan that we know we definitely have a contract with and we're comfortable with the rate structure. Next question. How are all the rapid changes impacting the clinician's actual service delivery to the client? Great question. I'm not sure we're seeing that change yet. We're hopeful that we don't suffer from the industry. We hope we don't suffer from a financial standpoint where we have to worry about, can we afford the care? Can we afford the staff, the physicians, to provide the necessary care? But I think what it's doing is, in terms of clinicians, it's forcing them to look at opportunities, and it's driving them to work more closely with us. The hospitals and physicians have been going in this direction for many years, and again, another theme you're hearing is that we're just catching up. Okay, how will Obamacare affect assisted living? I think it's also a little bit too soon to tell. I do believe that if more people, more folks are insured, which is the goal of Obamacare, that assisted living will be a covered entity and more widely accepted. Assisted living is growing. It's a very key part of healthcare, and I think it could only be a good thing for assisted living. I know that our facility, we work with many of the available assisted living facilities, and they too are interested in partnering with us. So I think it's just all part of the change that we're going. It's everyone having to work together. We might be winding down on questions. Actually, one more coming in, so please hold on. Tasha, how many folks do we have on today's call? 40 people on today's call. That's great. I think we have more questions than people on the call. Okay, next question. Do you believe that current staff of healthcare employees can effectively leverage analytics and dashboard systems and transition the information into medical progress instead of just quantity, people, and productivity? Well, that's going to be the challenge of very, very good leaders. We get overwhelmed by data. Very often, we know we need to look at quality, so it's very important that what you look at, you have the wherewithal, the ability to truly analyze it. You have to look at what's important for you. So having analytics, having dashboard is great, but you've got to use it. You can very easily be overwhelmed by data and not allow it to guide direction that you need to take. I hope that answers that question. There's another question coming in. Okay, will the new healthcare setting allow for technological advances? Absolutely. I think this is another one of those things that you can't stop. We're becoming more and more reliant on technology. You've heard the term telemedicine, And that very much is part of the new legislation. So I think we will continue to see technology advances well into the future. And the second part of that question, I think, was more of a comment with the goal of focusing on preventative care. And that's really the goal of telemedicine. If we are, we have a loved one at home and they want to be able to communicate with their physician, maybe can't get into the physician's office, and they're able to do a live video chat with a physician. The physician can maybe see the person. There may be nothing better than treating a person in person in the office. But I think modalities like that, like telemedicine, will really serve to be preventive in care. Good question. Okay, yet another question. Is the 5-year look back going to be affected by the upcoming changes? To the best of my knowledge, that is not changing. That look back period, which went from 3 years to 5 years a few years back, is, to the best of my knowledge, is still in place. And so people know what that refers to. That is for someone to obtain Medicaid eligibility so that Medicaid could cover a nursing home stay, that Medicaid, the state, looks back at people's spending patterns over a 5-year period. So that if someone has made payments to family or divested monies or to try to, quote, hide monies, if that's seen and that occurs over a 5-year look-back period, one could not be eligible for Medicaid. So I think the message in receiving this question is that if you are dealing with an issue with a loved one and you're concerned about expenses and affording permanent nursing home care, that's where elder law comes into place. Having access and investing in an elder law attorney would be important just for your own planning and safeguarding monies for the future. Next question. Is there undergraduate or master's training that focuses on interprofessional collaboration? And if not, do you see this need? I think that we in healthcare need to be more diverse than ever before. I know that if I look back early in my career, 20 or 30 years ago, I never thought things would be this complicated. I would need to know so much. And if you look at the importance of leadership, training, reading, knowing your legislators. I know this wasn't necessarily taught many years ago. These are things we all need to do. Things are changing so rapidly. The difficulty in staying on top of the changes, it's just dramatic. And again, we've all got to be more diverse. Okay, this question's come in. I am in Maryland. Okay. And our ACOs are selecting to work with skilled nursing facilities with low readmit rates. Oh, are ACOs selecting to work with nursing homes with low readmission rates? Yes, and that is exactly where quality comes into the equation. The insurers, the organizations like ACOs, they're looking at this. So why would they want to contract with a nursing home whose half their patients get readmitted within 30 days? They want good quality. We want to work with partners who are also producing good quality. And the data is out there. The published data is there. So that's why you have to know your data and choose partners who are providing good quality. Great question. Next question. How important is information technology with healthcare? I believe I had a similar question earlier. That was in terms of really technology, and I was referring to telemedicine. Information technology is important because without it, we're not going to have the data that we need. So it's one thing having data. It's another thing having the systems that can generate it, being out on the forefront, anticipating what insurers may be looking at so that you could address issues before others point out that you may have an issue. Next question. telemedicine is a positive accommodation, but at what cost in comparison to visiting patients? Great question. It's for the most part a comment. Some would argue that telemedicine would replace a physician visit. If it's used properly, it's used to complement care. It should not be used to replace care. Again, there's nothing like being in the physician's office, having a confidential one-on-one discussion and observation. Nothing can replace that, and we can't lose sight of that. Telemedicine should just be a complement to what we're doing. And the insurers are reimbursing for the use of telemedicine, but again, should be a complement, not a replacement. Well, that's great. I am very impressed by the questions, and I hope I've been able to answer them for all of you. And I'd like to just take this moment to thank all of you, thank the Hofstra folks for having me here today. Monica Conforti helped arrange this, so thank you, Monica. I hope all of you gained by being on today's call, and thank you. Have a wonderful day.